All right, greetings online students. I will be now putting everything together for you. We are on our 10th step of our 10-step recovery process for EKG interpretation. Please make sure you do them in the order. So you should be to step 10 now, the final step of putting it all together. All right, so without further ado, let's get started and see how much we can recall. All right, when we talk about dysrhythmia interpretations, it's important that we understand and are able to interpret ECG rhythms. For you to know that, though, you've got to know the electrical activity that's occurring within the heart. So we're going to have to start out with some basic terminology here about the electrical activity of the heart muscle, just a refresher to get you going. Now, if you looked at some of the other videos before you got started on this one, then you would have already went through some of this because she did an excellent job. Action potential causes cardiac muscles we know to contract and relax. And it does that because of certain electrolytes that's either on the intercellular part or the extracellular part that's responsible for what we call an action potential. And you'll remember that. If you'll remember, potassium's the major intracellular, sodium's on the outside, calcium is kind of like the gatekeeper. And when stimulated, we know that the membrane undergoes an electrical charge within the heart, and that's important for that to occur. We have depolarization and repolarization that can occur, and we've already talked about depolarization and repolarization. And even though we've not looked at any waveforms yet, this is what's happening in each waveform. Again, if you looked at my YouTube that I posted, she did an excellent job of explaining this. That in the atrium we have depolarization, in the ventricle we have depolarization, and then we have ventricle repolarization that occurs again. The conduction system, there are three main parts of the conduction system. There is the sinus, which is the SA node, sinus atrial node, and this is our primary pacemaker. You have the atrioventricular or AV node. This is our secondary pacemaker within the heart. And then the Purkinje fibers, which is the tertiary. So not the same meaning as you've been used to with primary, secondary, and tertiary pacemakers. So when the primary fails, the secondary kicks in. When the primary and secondary fail, the tertiary kicks in. These pacemaker cells are capable of initiating electrical activity automatically, and they actually act as a pacemaker would. Therefore, the heart's going to beat in the absence of any nervous system connection. It doesn't have to have the nervous system there because these act as the pacemakers of the heart. Now, the cardiac conduction system, if you're looking here, you can see again that there are electrical cells in the heart and they're arranged in a system of pathways called the conduction system, and that's this whole system. We know again that the conduction system consists of the SA node, and we know that's located in the upper atria. The AV node, which we know is located in between the atria and the ventricles. We know there's the bundle of His that's located in between here. And then we know it branches off into the right and the left bundle branch. And then into the Purkinje fibers. The SA node, when we're talking about the SA node, we know the SA node, again, is the one that normally paces the heart. This is our primary pacemaker. And if you remember back when she was talking in her video, she said the normal heart rate here is 60 to 100. So if you're pacing with your SA node, which is what a normal healthy adult does, you should have a normal heart rate of 60 to 100. This electrical stimulus then travels through the atria by way of intranodal pathways to what we call the AV node. The AV node is a cluster of cells located in the lower portion of the right atrium. And it in itself, it possesses two main functions. The first is to delay the electrical impulses in order to allow the atria time to contract and complete filling of the ventricles. The second function is to receive an electrical impulse, and then it's going to conduct it down to the ventricles via the AV junct and the bundle of His. Now, this pathway, if you remember, conducts a heart rate of about 40 to 60. And then if you remember, this is 20 to 40 when you get out here and you're relying on more of the bundle branch blocks and the Purkinje fibers. So the more we go, the less the heart rate that we're going to expect as the pacemakers are kicking in. All right, so common sense is going to tell you if you've got a heart rate of 30, your blood pressure is likely to be low and you're likely to be symptomatic. And it's likely that something here, these two have failed and this is kicking in way down in here. Okay. The electrolytes that affect cardiac functions, the positive charge and the negative charge ones. The mechanical and electrical cardiac functions we know are influenced by electrolytes. The major positive charged are your potassium, your sodium, and your calcium. Again, potassium being the major intracellular, sodium being the major extracellular, and calcium is kind of the gatekeeper at the heart. That's why we give people calcium channel blockers, so that it blocks the calcium and doesn't let it open the gate so that we don't have as many impulses to the heart. The major negative charge is calcium. And this is why it's important to monitor electrolytes. We just think about electrolytes in the blood system, but the electrolytes are responsible for all of this conduction system that we were talking about over here. Therefore, it's going to affect cardiac activity. Make sure you're paying attention then when you have cardiac electrolyte imbalances to cardiac arrhythmias. So in a nutshell, the electrical impulse begins in the SA node that's located in the upper atrium. This causes atrial contraction. The impulses then travel through the atria along the intra-atrial pathways to the AV node located near the center of the heart. After leaving the AV node, the impulse moves down the bundle of His through the right and left bundle branches and into their Purkinje fibers, causing ventricular contraction, then followed by repolarization or relaxation. Then the cycle begins all over again. All right, one of the things that we are going to do a lot is do telemetry monitoring on the floor. And this is checking primarily lead 2, and we do this by only placing, usually on the patient, 3 leads. The EKG cables are often color-coded for ease of application to reduce confusion about what electrode is going to go to what lead. The negative lead is usually white, so the negative lead over here is usually white. The positive lead is usually red. And the ground lead down here, the positive's red, and the ground lead can be black, yellow, or brown. I've seen them all different colors. So for a lead 2 setup, a popular phrase is white to right, red to ribs, and black left over. Okay, so black's in the left, it's left over. Okay, so if it's black, green, or brown, it goes over the red. Okay. Another phrase is smoke over fire. Red being the fire, black being the smoke going over the fire. So those are some little things just to help you. So white to right, red to ribs, smoke over fire. So hopefully that will help you a little bit on what colors go to what. All right. EKG leads. A lead is a record of electrical activity between 2 electrodes. There are 3 types of leads, each with a negative and a positive pole. Think of a positive electrode as your eye. And think about wherever you put that positive electrode on the body is going to determine how the heart is seen in that lead when you're getting ready to actually do, for example, a 12 lead. Now, this is typical EKG paper that you will see, and this is the typical explanation of each box. You can see here that the EKG paper is just like graph paper. It is made up of small and large heavy line squares. If you look, there are 5 small squares between the heavier lines. 1, 2, 3, 4, 5. On the EKG paper, each time is measured in seconds. Time is measured in seconds. So when you think about time being measured in seconds, each square is 1 millimeter in length and represents 0.04 seconds. So that's right here. Each square is 1 millimeter, and each one represents 0.04 seconds, each little square. This is something you're going to need to memorize. Each larger square is 5 millimeters in length, so that would be 5 of those, being 5 millimeters in length, and therefore represents 0.20 seconds. In other words, you would multiply those 1, 2, 3, 4, 5 by this 0.04, and you're going to get 0.20, and that's what this is showing up here. Okay, so each square is 1 millimeter. Each millimeter is 0.04 seconds. There are 5 millimeters in one large square, so that would be 0.20 seconds. Okay. All right, to evaluate an EKG strip, it is standard practice to print a strip of 6-second duration. And you'll remember when I posted that video on the 6-second rule of how to figure heart rate. That is very common, so that's 30 small blocks. The type of EKG printout is going to be adequate for the majority of your rhythm interpretations. A continuous strip can always be printed, especially if something unusual presents and it requires closer inspection, then they can go back and print that little section and see what's going on. So if you don't understand something about the actual EKG paper, let me know. All righty. So the EKG paper is made up of small and large squares again. The smallest is 1 millimeter and 1 by 1. The horizontal axis represents time. It records at a constant speed, and the horizontal unit represents 0.4 seconds. So here is what a typical EKG complex would look like. The tracings recorded from the electrical activity of a heart forms a series of waves and complexes, and these have been labeled. And this is the PQRST, so it's in the alphabet, so it should be easy to remember. And these waves or deflection occur in regularly occurring intervals in a healthy individual. So you'll always have a PQRST, PQRST. There should be 1 P wave for every QRS complex in a healthy adult. So you can see here, we're going along. Here's our P wave. This is what's going on in the SA node. And if you'll remember, she went over this in detail of what each one of these represent in that video. So go back and look at that if you need to. From the beginning of the P to the beginning of the QRS, you will remember, is what's called the PR interval. If you'll start here, this is your Q, your R, and your S. And then your S goes through here, and then you'll have your ST segment that's between your S and your T. And then your actual T finishes it off, okay? So your ST segment starts here, the flat part, after it finishes till it starts the hump. And then from the beginning of the S to the end of the T is the ST interval. Usually we do not measure the ST interval. We measure the PR interval and the QRS complex. Okay. All right, so let's talk just a little bit about the P wave. The P wave is electrical impulses, again, that's originating in the SA node that's represented on the EKG with a waveform that's called, again, a P wave. Okay. A P wave is what has fired in the SA node, and it's depolarized in the right and the left atrium. It is recognized as the first upward deflection from the baseline. So the first upward deflection from your baseline is always your P wave. And it resembles kind of like a small upward hill or a kind of a bump. And once completed, it returns to the EKG baseline and gets ready to be followed by the QRS complex. Okay. Now, the Pwave, again, should not exceed 0.2 seconds as it's measured. Should not exceed 0.2 seconds. It represents atrial depolarization and the spread of electrical impulses through the right and left atria. The normal Pwave is very smooth and rounded, no more than 2.5 millimeters in height, which we usually don't measure the height unless it's just very pronounced. It's normally, again, preceded before every QRS complex if it's a normal, healthy individual, and no more than 0.1 seconds in duration or width. No more than 0.11 seconds in duration or width. Okay. All right, the PR interval is measured from the beginning of the Pwave to the beginning of the QRS complex. Okay. And there's a picture of that on page 860 in your book is where it talks about this. And it shows you a wonderful little graph that you can look at along with this. So again, this is measuring from the beginning of the Pwave to the beginning of the QRS. Okay, the normal PR interval, this is the first thing you're going to have to measure with everything. A normal PR interval is 0.12 to 0.12 seconds, and that's what I was talking about earlier, being 1.2 seconds, no more, was your PR interval, okay, the PR interval. 0.12 to 0.20 seconds. So from here, start of the Pwave, to the start of the QRS complex, the PR interval should be no more than 0.2 seconds. Well, each one of those, if you remember, were 0.04. So it shouldn't be any more than 5 blocks long. Okay, shouldn't be any more than 5 blocks long. If you're looking at the EKG complex here, the tracing recorded from the electrical activity of the heart actually again forms a series of waves, we know. And the next one that we're going to be looking at is the PQRST waves. And these waves are deflections occurring again in a healthy individual. You can see there the ST segment, the QRS. It talks about the PR interval here and how to measure those. So when you're looking at the complex again here, the tracings recorded from the electrical activity of the heart, again, when we're looking at the QRS, it's going to be from where the beginning of the Q starts till the end of the S starts, okay? So what makes up the PQRS? Well, it's from here to here to here to here, everything in dark. So this is the PQRST. And you'll see as you're starting to get ready to go out, there's part of the S as it's getting to go into the T segment. So if you were to break this down, this is what it would look like. This part of it is your Q wave. That would be right there. This part is known as your R wave. That would be the upper part here. And then this lower part is known as your S wave, okay? So you have your Q, your R, and your S wave, okay? And then we start into our T segment, and that's what that's showing over here. All right, the QRS complex is measured from the beginning of the Q wave to the end of the S wave. So from the beginning of the Q to the end of the S, and she showed you again in that video how to measure that. The normal range is 0.06 to 0.12 seconds, or 1.5 to 3 boxes is about what it should be. The QRS complex can vary from person to person as well. Again, if we go back and look on page 860, that gives you a visual again of the graphic paper. And then under figure 30-12, it shows you how to measure those. If you were measuring this one, you can see there, measuring the PR interval, you're measuring from the beginning of the P to the beginning of the Q, okay? And that, if you look at this one, it's 1, 2, 3, 4, almost 4 boxes. And then if you look at the top, it shows you how to measure the QRS from the beginning of the Q to the end of the S, which is when it starts deflecting back up. Once it starts deflecting back up and starts that straight line, that's where you would measure to. And then you can see here, it's no more than about almost 2 boxes is what this one is, okay? It also tells you there the QT interval. You will not be measuring that. You only have to measure the PR and the QRS intervals, okay? So that's all you need to worry about. As you can see here, everyone's QRS can look a little bit different. So don't get into that pretty rhythm and thinking, oh, everyone's sinus rhythm always looks textbook, because it does not. There are different types of QRS complexes. Each QRS complex can look a bit different, but depending upon when they're depolarizing in the ventricles. So again, just know that they can look different sizes and shapes. All right. Now the ST segment, if you'll remember, was at the end of the S, which is what we would measure here. If we were measuring QRS, we'd measure here to here. But the ST segment starts where the flat line starts to right beginning to where it goes uphill to the T, okay? Again, you are not going to have to measure the ST segment. Just know that it does exist. It's between the QRS complex and the T wave, and that it represents the early part of repolarization of the ventricles. Abnormal segments, like depressions of more than 1 millimeter, is suggestive of ischemia. So if you looked at this ST segment, and this wasn't a straight line, but it was depressed here, then you would think this person's probably had a heart attack in the past and has some ischemia resulting from it. Now, an elevation, if you look at the ST segment and it's got a hump or it's elevated, that indicates they're having an MI or there's been some myocardial injury. So ischemia is a downward slope, and MI or myocardial injury is an upper slope. Okay, so that's the most important thing you need to remember about an ST segment. The T wave represents ventricular repolarization. If you'll remember, that is the relaxation. The normal T wave is asymmetrical, and it's not normally greater than 5 millimeters in height. Okay. So what is an abnormal T wave? It's a tall peak in a T wave that's seen with certain things like hyperkalemia. That's the main thing you watch for, a peak. So if you're looking at this T wave and you come along and it peaks way up here and comes down, then that is common with hyperkalemia because you're doing it extra, it's getting some extra excitement in there. Deeply inverted T waves are seen with cerebral disease. So someone's been in a car accident, has got cerebral injury, then you would see a depression here. It would be inverted T wave, okay? Instead of going up this way, this would be completely inverted and going downward. So that's the main two things you need to remember about the T wave. If it's tall, peaked, hyperkalemia. If it's inverted, cerebral disease. All right. So that was an explanation of the PQRST segment, okay? Again, looking at rhythm interpretation, you want to look at certain things, and I also posted a handout that you will want to make sure that you keep this beside you when you are doing your little test, because this gives you the steps that you go through to figure out about the rhythm interpretation. You're always going to look at the rate. Is this a regular rhythm? Is there P waves? What's the intervals? What's the general appearance? And then what's the rhythm interpretation? So if you look at your handout that I gave you, EKG rhythm analysis, which I believe was step 9, first thing you're going to do is always identify the P waves. So you're going to ask yourself, number 1, are P waves present? Number 2, do the P waves all look the same? Do they have the same shape? So are they present and do they look the same? And then the third thing you're going to ask yourself, is every P wave followed by a QRS complex? So always look for a P wave. Do they look the same? And do they have a QRS complex behind them? Step 2, you're going to identify the QRS complex. Are they present? Do they look the same? Is there one for every P wave? Okay. Then the third step, you're going to measure the PR interval. The PR interval should be within normal limits, 0.12 to 0.20 seconds. Okay. How do you measure the PR interval from the beginning of the P wave to the beginning of the QRS complex? Is the PR interval the same for every EKG complex? So you need to measure that out with each complex. Is it consistent? Is it about the same, or is it different? And then you want to measure the QRS interval. The QRS interval started at the beginning of the P and ended at the beginning of the S. Is it within normal limits? 0.06 to 0.12 seconds. Okay, and that's the norms that your books gives for the QRS interval. Okay. Is the QRS interval the same for every complex? Then you have to determine the atrial or ventricular rhythm and rate. Okay, so if you can follow that along with that, then you should be just fine. Okay. All right, the rate measurement. To determine the atrial rate, first thing she told you, if you go back to that 60-second, if again, a 6-second rule. So if you don't remember how to do that, go back and look at the 6-second thing again that I have posted, because she went over this in detail, how to measure the atrial and how to measure the ventricular rate. To determine atrial rate, it's how many P waves are in a 6-second strip times 10. To determine the ventricular rate, it's how many R waves are in a 6-second strip times 10. If you'll remember, 6-second strips are 30 small boxes. So you count off 30 small boxes, how many P waves times 10 is your atrial rate. You count off 30 boxes, how many R waves is in a 6-second strip times 10 is your ventricular rate. Now, they should be the same unless the rhythm's irregular. So, unless the rhythm's irregular and something's going on with your heart, your atrial and ventricular rate should be the same. Okay. All right. We've already talked about measuring PQ and measuring the QRS complexes. So, if you were to get with this one and you were to look at the beginning of the P here, or let's do this one, the beginning of the P to the beginning of the QRS, you would get about how many boxes? 1, 2, 3, about 3 or so boxes, and that would be 0.12, which is normal for the PR interval. Okay, 0.12 is normal for the PR interval. Then for the QRS, it's where the Q starts to the beginning of where the S starts. So you would get about 1, 2, 3 boxes. So 3 boxes would be normal, because that would be about 0.12. So you want to make sure that you're measuring these boxes very carefully. And it is hard sometimes to see them. You have to really, really look to make sure, especially when it's a smaller one. For test purposes, I will have these blown up to where you will be able to measure them really well. So here's just a practice one to measure the rate, the rhythm, the regularity, the PR, and the QRS interval. So if we wanted to measure the rate, we would have to count all these boxes. And you would count these 5, 10, 15, 20, 25, 30, 35. So you would do from about right here to here. So the first thing you would count is your P waves. 1, 2, 3, 4, 5, 6, 7. So if you're counting from here, starting in here on this one, because this is with that one's not in your actual rate, that would be 1, 2, 3, 4, 5, 6, 7. So your heart rate would be 70. So this would be a normal sinus rhythm because there's a PQRS, 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 and they all look the same. So it's a regular rhythm. It's normal sinus rhythm. And then you would go back and measure your PR intervals. So you would measure from the beginning of the P to the beginning of the QRS complex. Okay. So it looks again about like 5 boxes, so 0.20, so that's normal. And then you would measure your QRS from the beginning of here to the beginning of here. And again, it's a little hard to see on this one, but it looks like about maybe 2.5 boxes, so that's normal. So again, it just takes, you're just going to have to get used to measuring within those normal limits of those boxes. All right, so let's talk about some of the rhythms. Let's talk about sinus rhythm, okay? Sinus rhythms is when atrial depolarization is normally occurring, and the normal PR interval again is 0.12 to 0.20 seconds. The QRS complex is less than 0.12 seconds, so about 3 boxes, no more. The number of P waves equal the number of QRS complexes in order to have a sinus rhythm. And the rate's going to be again between 60 and 100. Now, if the rate's below 60, that becomes a sinus bradyarrhythmia. If the rate becomes over 100 to 180, it becomes a sinus tachyarrhythmia. Over 180, we're really getting into what we call SVT, sinus ventricular tachycardia. So sinus tach between 100 and 180. So here is some neat rhythms that are some nice sinus rhythms. You will see here the first thing you're going to look at, if you go back to your little handy dandy handout I gave you. Let me go back and find mine. Oops. First, I'm going to ask myself, are there P waves present? P wave, P wave, P wave, P wave, P wave, P wave, P wave. Yes. Do the P waves all look the same? P wave looks the same, same. Yes. Is every P wave followed by a QRS complex? QRS, 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 QRS. Yes. Are the QRS complex present? Yes. Do the QRS complexes look the same? Do they have the same shape? And now this is when you would get a piece of paper out and you would walk them off to see if they are the same. So you would get your paper up here and you would mark and mark, and then you would walk these off. Same, 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 and same. So they walked off. You can also walk off your P's if you wanted to walk off your P's. They should be about the same. And they do walk off. Your P's walk off and your QRS's, so it is a normal rate and rhythm. Then you would go back and measure your PR intervals. And again, with this, I would hold up a piece of paper, and I would know that it starts at the beginning of there to the beginning of the Q. And if you looked at that, again, it's hard to see with these small boxes, but it looks like it's around 4 boxes. That would be normal. And then your QRS starts at the beginning of there and goes to where your S is starting. So it looks like about 3 boxes, so that would be okay. So I would say this is a typical, yes, follows a normal sinus rhythm. To figure out my heart rate, 1, 2, 3, 4, 5, 6, 7, looks like 70. All right, now I'll show you this other one just to show you that, again, remember what I said earlier. You may be looking at it in different leads so that your QRS complex looks upside down. You may be looking at it, and everyone's QRS may look a little bit different like we talked about earlier. But if you look at this one, you've got your P waves, you've got your QRST, it's just upside down. P, QRST, P. So this is a typical normal sinus rhythm as well. Again, this is what we want to see with everyone's strip, but this is what we tend to see at times too. So don't let that fool you. Just follow your rules. Okay, if it falls within all those rules, then it is normal sinus rhythm. Okay, that's just in a different lead. And you'll learn to read the different leads. Okay. Sinus Bradycardia is something that you may see. This may be normal in physically conditioned adults and during sleep. Causes may include disease of your SA node, increased vagal tone or vagal maneuvers, hypoxia, hypothermia, and some medications can induce it. Potential treatments, if they're asymptomatic, you're just going to observe them. If they become symptomatic, then oxygen, atropine, which increases the heart rate. If you don't know much about atropine, you need to look it up. And dopamine if they become hypotensive, which we've been over dopamine when we did ICU. If those things do not help, then they may end up actually with a possible pacemaker as well. So asymptomatic observation, symptomatic oxygen, atropine, dopamine if they become hypertensive with possible pacemaker placement. So let's look at this characteristic strip. If you look here, we're going to go back to our little handy dandy sheet. Identify the P waves. Are there P waves? Very small P waves, aren't they? I mean small P waves. But there are the same, and they do look the same before every QRS complex. QRS, 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 QRST, QRST. So it's all there. All right. Again, are there QRSs? Yes, and they all look about the same. So we can pretty much determine, and then we can walk it off to see again if the rate is about the same. And we can see here that it is, so it's normal. You can also walk off these little P waves if you wanted to, and they are walking off as well. So our P waves and our QRSs are walking off. So this would be normal sinus brady with a heart rate of 40. Okay. Here's another one with a heart rate of 30. Again, this is in a different lead. So you got your P, QRST, P, QRST, P, QRST. Everything's there. It would walk off if we were to walk it off. There's also something called calipers that you can buy. Paper does just as well, but I will show you an example so you know what the calipers do. The calipers, again, you would walk off your, what we call walk off. This would be about right for that, so that if you were to take that and flip it, see it walks off. If you were to take your P wave to P wave, then it would just about walk off. That means walking when you can flip it and then it continues on to the same thing. Again, paper does the very same thing if you mark the paper. So you do not have to have the calipers. They're just nice. All right, so this is a normal sinus brady with a heart rate of about 30. Okay. Sinus tachycardia is another rhythm that you're going to see. Sinus tachycardia, when again your heart rate gets above 100 up to 180. If they're asymptomatic, you're just going to observe them. But if they become symptomatic, you're going to have to treat the underlying cause. If it's dehydration, you're going to give them fluids. If it's anxiety, you're going to have to give them medicines to decrease their anxiety. And if that doesn't help, then drugs such as beta blockers may be given to help actually slow the heart rate down. Okay. So here is a typical picture of what we would call sinus tachycardia. And if you look here, there's a P, QRST, P, QRST, P, QRST, and you can see the T and the P's getting very close to each other here because they are so tacky, and that's what happens when you get tacky. The T and the P get very close because you run out of space. So if we were looking at this, it is normal. Again, if we wanted to see if it was a regular rate, then we would try to walk it off. So we'll try here with the calipers again to walk that off. So there's that. As you can see, it is walking off just fine. So it is normal. I pulled those. And you can see here that your P waves would walk off as well. So this is a normal rate and rhythm, and the P's and the QRS complexes walk off. You can see here our rate's going to be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, about 120. So our heart rate's up. So this is a typical picture of what you would expect to see with sinus tachycardia. Okay. Of course, if someone's in sinus tachycardia, then you want to make sure that you're checking their blood pressure. You're seeing if they've got syncope, palpitation, shortness of breath. They need to lie down to prevent any falls from occurring. And again, medication administration to help with that. All right, then you got your atrial rhythms, and then I'm going to pause this one and I'll come back and do part 2 so that I don't put too much on this one. Your atrial rhythms, that's the only ones that I want you to know about the sinus. There are other sinus rhythms. There's sinus arrest. but we are only learning basic EKG interpretation. So with that said, there are some rhythms in here that I will not be covering. I'm covering the most common in this, and so in your sinus group, I'm covering normal sinus rhythm, sinus Brady, and sinus tach. I'm not covering sinus arrhythmia or sinus arrest. Okay. All right. So your atrial rhythms, the first thing you have is what's called a PAC. A PAC is a premature beat or an early beat that's identified by their site of origin as an extra beat. A PAC occurs when an irritable site within the atria is discharged before the next SA node impulse is due to discharge. So it's kind of like it just beats itself to it and does it a little bit quicker so that you end up with an extra beat. If the irritable site is close to the SA node, then of course a P wave is going to look similar to the SA node peed. The P wave of the PAC can be flattened, it can be notched, it can be pointed. The PR interval may be normal or prolonged depending upon the prematurity of the beat. The pulse, when you feel it's going to feel irregular because of that extra beat that you're getting. As far as treatment with these PACs, usually treat the cause. They may get medicines such as digoxin, verapamil, or propranolol. So if you look here at this one, diagnostic-wise, you would see that we're sitting here going along PQRST, PQRST, PQRS, and you can see here we get a jumbled up extra beat in here so that it throws things off. And then you can see you'll start returning back and going back to normal. So it's a completely normal thing. We have our PQRST, PQRST, and then we have an extra beat in here. Anytime everything looks normal, everything walks off except for that one extra beat, then you know that they have thrown what's called a PAC. Again, the P wave before that one can look a little bit different, distorted. You can see there's the P wave looks good, the P wave looks good, the P wave looks good, and here the P wave looks a little distorted. Here the P wave looks good, the P wave looks good because it prematurely fired off, okay? So you always look for a distortion of the P wave before it and an extra beat with everything else being normal, okay? All right. SVT, supraventricular tachycardia. There is a good picture in your book on page 869 of SVT. Okay. Supraventricular tachycardia. You can see down at the bottom, you've really got it going here. It's a fast rate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. That one's got about a rate of 200 beats per minute, for an example, on the bottom of page 869. So SVT is when the rate is just going crazy. Okay. Supraventricular tachycardia. When you get to looking at supraventricular tachycardia, there are no PR intervals. It is just going almost continuously into each other, so you can't measure a true PR interval. It's an arrhythmia with a rapid ventricular rate and a very narrow QRS complex. You can see that's not even hardly a box wide there. The rate can be anywhere from 150 to 250, so even though normal sinus rhythm can go up to 180, if it stays up around 150s to 180, some people will go ahead and call that SVT. The P wave is not seen, it's buried in the QRS complex. So for test purposes, you really have to look and see if you can still measure the PR interval. If you can't measure a PR interval, then you're really at the point that you're at supraventricular tachycardia. Treatment is treat the cause. If it's stress, treat the stress. They may have to do vagal maneuvers to help slow it down, oxygen, and if none of those help, then cardioversion, which we will talk about in a little bit. So you can look here diagnostically. Again, this is in a different lead. This is about a heart rate of 120 as well, but you can tell that you can't measure a true PR interval. It's almost like it's running into the T. Whereas up here, when we did sinus tachycardia, you can see that you still had very plain PQRSTs, PQRSTs, okay? So that's the main difference. You're not going to be able to measure that that PR interval, okay? And you're going to have very narrow QRS complexes with SVT. All right, the two other common ones that you're going to see is atrial flutter and atrial fib, okay? Atrial flutter is regular, okay? It can be irregular, but almost always atrial flutter is regular. It's a rapid, regular atrial rate that can exceed up to 350, and you usually can't get a true count of it. So with counts, you usually just put none. With atrial flutter, and it does tell you here when you're talking about atrial flutter in the book on page 867 through 868. It talks a little bit about atrial flutter. Atrial flutter, again, this causes, if you think about it, the atrium, as that lady was telling you in that one video, is sitting there just fluttering. So they're fluttering instead of contracting. And when they just sit there and flutter and don't actually contract, that decreases cardiac output and it pulls that blood so that it becomes stasis there. Well, now you're at risk for clot formation and strokes because of that blood pooling. There's no identifiable P waves with atrial flutter. Instead, you get what's called the sawtooth appearance. Okay. The PR interval cannot be measured, and the QT cannot be measured. Atrial flutter, the treatment is cardioversion. There are medications that you give, DIG, propranolol, and cardizem. If they are chronic in atrial flutter and they can't get out of it, then they put them on anticoagulants because of this blood stasis and pooling at risk for clots and stroke. I've included a YouTube here on cardioversion. You will need to watch that. This can be done at the bedside. Usually they want them NPO for 6 hours prior to cardioversion. If they're on DIG, they'll withhold that for 48 hours. They will give them some type of IV sedation. That will usually begin at 10 to 20 joules, and they can go up to 360. The more they go up, the more likely they are to cause some damage and can cause burns. Oxygen, the outcome, of course, is we want them to go back into a normal sinus rhythm. There is a difference between, when you think about cardioversion, between that and defibrillation, and that is on page 890 in your book, if you'll turn over there real quick. It talks about defibrillation is basically the same as cardioversion in that electrical voltage is delivered to the myocardium to terminate unwanted rhythms, except defibrillation is done in the emergency situation for life-threatening dysrhythmias. Defibrillation is indicated for patients in ventricular tach, VFib, when they've lost consciousness, and CPR is in progress. So you can, again, set it at about 360 when you're doing defib, and then evaluate each rhythm after each shock and continue CPR, hoping that the patient comes back. Whichever type of pad is used, it must have a conducting medium to prevent burning the patient's skin, and even then I have seen people with burning skin. Shows you a picture on defibrillation paddles on page 890, and then safety criteria when using a defibrillator. You're going to use designated conductor pads. You're going to use designated conductor medium, the gel, paste, and sheets that you're supposed to use. You want to place the pads or paddles so that they're not in contact with the patient's clothes or bed linens, or place near medication patches or monitor leads. Do not place the pads or paddles near a direct oxygen source as well. For cardioversion, defibrillation must be set in a synchronized mode with defib and asynchronized mode. For cardioversion, make sure the monitor leads are attached. Do not charge the defibrillator until ready to shock, and keep your fingers off the discharge buttons until you're ready to. Exert enough pressure on the pads to ensure adequate contact prior to discharging the volt. Call everyone to clear the area prior to discharging. Document the procedure and the effectiveness, and inspect the skin for burns. Alright, so here is a typical picture of what you would see with atrial flutter. And if you remember back here when we were discussing atrial flutter, we said there's no P waves, but you see a sawtooth appearance, a sawtooth. Does everybody see the sawtooth appearance? And usually it's a normal ratio. You can say in here again, it's like a 1, 2, 3. Okay, now here we've thrown a little bit of a offbeat. We've thrown a, looks like a PAC. But if you'll look in here, we go 1, 2, 3, QRS, 1, 2, 3, QRS, 1, 2, 3, QRS. But you can't measure PR intervals in this. So what we do here is call this a 1 to 3, a 1 to 3. So this is atrial flutter in a 1 to 3 ratio. For every 3 Ps, there's 1 QRS. Okay, and usually you're going to see that. Again, if I was to try to walk that off for the most part, except for my extra beat there, it should be about normal, and it is. Okay, and then it goes back to normal after this extra beat. So that's what you're going to see in atrial flutter. Now, in atrial fib, and this is on page 868, it talks about, and you can see another picture of atrial flutter on the top of page 868 for a visual. This one again has about a 3 to 1 block, or 3 to 1 flutter, sorry. Now, if you look down at the bottom, it goes over atrial fib. So how do I know the difference in atrial fib and atrial flutter? Well, atrial fib is not going to have the sawtooth appearance for one thing, and it's going to be irregular. The atria are just sitting there quivering instead of contracting, and as a result, again, that decreases cardiac output. Again, blood's going to become stasis, pooling's going to occur, and they're going to become risk for clots and stroke. So whether it's atrial fib or atrial flutter, they both have the same output, same outcomes: decreased cardiac output and blood stasis and pooling. There's no identifiable P waves. The PR interval cannot be measured and is very irregular. So for atrial fib treatment, first they'll start with drugs like digoxin, beta blockers, and calcium channel blockers. Then they'll put them on anticoagulant therapy, cardioversion, vagal manipulations, maneuvers, having them bear down a lot, oxygen. So they will try things like this. Again, they're going to try all of this before they try the actual cardiac conversion and have to do that. So this is a typical picture of what you would see with atrial fib. And if we remember back when we were talking about atrial fib, it says no identifiable P waves. So look before each QRS. Do you see a P wave? There is absolutely no identifiable P wave. Potentially one there, but not there. So no P waves, hardly. The PR interval you can't measure because you don't have a P wave. And it's irregular. So let's try walking this one off. So about right there to there. And if we were to walk it off, you can see it's very irregular. There's nothing regular about it. Not a single one of them. So that's your big clue, is when it becomes irregular that we have gone into atrial fib. All right, so hopefully you're up to me with this point, and I'm going to close it for now, and I will come back and pick up on the junctional rhythms. Thank you.